Welcome to the Providence authored Basic ECG course. This is Lesson 2, Sinus Rhythms. Be sure that you have your handout as we're going to use that several times throughout the presentation. During this session, we're going to review various rhythms that are generated from the sinus node, discuss waveforms and timing differences between the various sinus rhythms, define symptomatic versus asymptomatic assessment findings, and discuss appropriate treatment options that are available for the patient exhibiting intolerance to the rhythm. This slide depicts normal sinus rhythm. You can see by the strip at the bottom of the page, everything is nice, normal, and regular. The impulse originates in the SA node, travels through the atrial tracts to the AV node, down the bundle of His, the right and left bundle branches to the Purkinje fibers. For this slide, you're going to need your handout. You may need to pause the video while you gather your materials and review the detail of the slide. Remember, in normal sinus rhythm, there should be one P wave for every QRS complex. There's coordination between the atria and ventricles that make this a nice regular rhythm. You can see the rate should be between 60 and 100, and it should be both regular for the atrial and the ventricular rates. P waves are uniform and look the same. The PR interval should be within the range of 0.12 to 0.20. The QRS duration should be 0.12 or less. And the QT interval should be half or less of the R to R interval. So what do we expect for hemodynamic effects from this rhythm? Well, this is a normal natural rhythm, and there shouldn't be any issues that are identified when you do your patient's assessment. You should see signs and symptoms of adequate perfusion, and you just continue to monitor your patient. This slide depicts sinus tachycardia. You can see by the strip at the bottom of the slide that it's still a nice regular rate with one P wave for each QRS complex. However, the rate is faster. The impulse still originates in the SA node and travels down the atrial tracts to the AV node, bundle of His, right and left bundles, and the Purkinje fibers, just like in regular sinus rhythm, except the rate is accelerated. For this slide, you're going to need your handout again, and you may need to pause the video to look over the details of this slide. So some of the characteristics of sinus tachycardia include the rate being higher, between 101 and 150. It should be regular for both the atrial and ventricular impulses, and it should also have uniform appearing P waves, just like in sinus rhythm. The PR interval and the QRS duration and the QT interval should all be just like we saw with sinus rhythm. Let's talk for a minute about the causes of sinus tachycardia. It can be as simple as anxiety or fear. And if we look at the little note here, usually a response to normal physiological situations like exercise or sympathetic tone, that stress, fight, flight, anger can all cause our heart rate to elevate. But I always think it's got to be something more as a nurse when you're seeing a hospitalized patient's heart rate go up. I always want to investigate further, not just assume it's something as simple as worry or fear. So hypoxia, hypovolemia, anemia. You can see some very big issues like coronary syndromes. So definitely, anytime you see sinus tachycardia, you need to ask why. The hemodynamic effects of sinus tachycardia often are minimized by nurses because the patients are generally asymptomatic except for complaining maybe of a rapid heartbeat. But cardiac output can be reduced, which shortens the ventricular filling time and decreases volume that is collected at the end of diastole. We can see a reduction in coronary blood flow, which could result in ACS or chest pain, and an increase in myocardial oxygen consumption. So angina, if patients have underlying coronary artery disease, or chronic tachycardia can actually lead to systolic heart failure. So how do we treat sinus tachycardia? Well, our goal is obviously to slow the heart rate down. We want to investigate why they're having sinus tachycardia in the first place. So the treatment is aimed at correcting that underlying cause of it. So for example, if it's hypovolemia, we're going to use fluid replacement. If it's pain, relief of pain. We're going to remove any offending medications or substances. Think about fever reduction, anxiety reduction, what's causing it, and then treated. And in the case of an MI patient that's having sinus tachycardia, they can be treated with beta blockers such as metoprolol to slow their heart rate down and decrease the overall myocardial oxygen demands. Sinus bradycardia. Again, you can see the strip at the bottom of the page, which shows a nice normal rhythm, just slower than what we've been looking at. And again, the impulse originates in the SA node, travels down the atrial tracts to the AV node, down the bundles of His to the right and left bundle branches and out to the Purkinje fibers. So that same normal sinus conduction pathway. Go ahead and pull your handout out, and you may need to pause the video to review this slide. The characteristics of sinus bradycardia are the same as for other sinus rhythms, except that the rate is less than 60 beats per minute. You see that nice regular rate both for the atria and the ventricle, 1 P wave for every QRS complex. The P waves are uniform in appearance, and the PR interval, QRS duration, and QT intervals are the same as for other sinus rhythms. Let's talk about the hemodynamic effects of sinus bradycardia. It can be pretty normal for physically conditioned adults and during sleep. So not every time you see a low heart rate is it something to be concerned about. But remember that equation of cardiac output equals stroke volume times heart rate. So whether of atrial or ventricular origin, decreased cardiac output can result with bradycardia. And once there's a significant drop in cardiac output overall, arterial pressure dramatically decreases. This reduced pressure results in syncopal episodes and hypotension. Decreased cardiac output may lead to ischemia or hemodynamic compromise. Do we treat all cases of sinus bradycardia? Well, the answer is no. We only treat symptomatic bradycardia. And in that case, we're looking for those serious signs and symptoms like decreased level of consciousness, angina, low blood pressure, those kinds of things. And so our treatment goals are to increase our ventricular contractions. And to do that, we begin by applying oxygen, ensuring the patient has a patent IV, and we start out with atropine 1 milligram IV push, and that can be repeated every 2 to 3 minutes to a maximum of 3 milligrams. If atropine is not working, we want to consider transcutaneous pacemaking. Dopamine and epinephrine drips can be used, especially in the case of refractory bradycardia that is also still symptomatic. Sinus arrhythmia. This is originated just like other sinus rhythms through the SA node, down the atrial tracts and AV node, bundle of His, right and left bundle branches, and into the Purkinje fibers. You'll notice the strip at the bottom of the page is an example of that sinus arrhythmia. You again see 1 P wave for each QRS. You see that they all look similarly. We just noticed that the SA node initiates the impulses irregularly. Pause this video for a second and grab the little speaker icon at the top of the page, and you can listen to what a sinus arrhythmia sounds like. For this slide, go ahead and pull out your handout again, and you may need to pause the video while you review the slide. So the characteristics of sinus arrhythmia, again, you see that nice regular 60 to 100 beat per minute. It can be a little bit slower or faster, but the rhythm is irregular and it phases with respirations. Heart rate will increase gradually during inspiration, so the R to R interval shortens, and it decreases with expiration where the R to R interval lengthens. The P waves are uniform, they're usually the same, looking with every QRS complex, and you see the PR interval, QRS duration, and QT are the same as other sinus rhythms. And if you notice in the strip below, you can see that the sinus node rate can change with inspiration and expiration. It will speed up with inspiration as you inhibit the vagal nerve and decrease with expiration as you stimulate the vagus nerve. Sinus arrhythmia is one of the most common dysrhythmias that you'll encounter. Respiratory sinus arrhythmia is a normal phenomenon that occurs with changes in intrathoracic pressure and vagal nerve stimulation. It's very, very common in children and often found in young adults as well. Let's talk about the hemodynamic effects of sinus arrhythmia. Most patients don't experience any cardiovascular symptoms. Non-respiratory sinus arrhythmia is much more likely in older individuals with heart disease, and it's also common after acute inferior wall MI and may be seen with increased intracranial pressure. Interventions are not usually required for sinus arrhythmias unless they're accompanied by bradycardia that results in hemodynamic compromise. If hemodynamic compromise is present, consider using atropine 1 milligram IV push. Let's talk about wandering atrial rhythm, or WAR. Please get out your handout and pause the video if you need to take a minute to review this slide in a little more detail. Wandering atrial rhythm is also called multifocal atrial tachycardia, or MAT, and the rate is usually 60 to 80 beats per minute, and the rhythm is generally irregular. The P wave morphology changes from beat to beat, and you must see at least 3 different varieties of P waves in order to ascertain that that's what you've got. The PR interval is usually less than 20 seconds and can be variable, and the QRS complex is usually normal. Atrial tachycardia is a form of supraventricular tachycardia originating within the atria but outside of the sinus node. Some of the ECG features that you'll see is an atrial rate of more than 100 beats per minute. The P wave morphology is abnormal when compared to a sinus P wave due to its ectopic origin. And there's usually an abnormal P wave axis. For example, you'll see an inverted P wave in the inferior leads of lead 2, 3, and ABF. You should see at least 3 consecutive identical ectopic P waves. QRS complexes are usually of normal morphology unless there's a pre-existing Brundle branch block, accessory pathway, or a rate-related aberrant conduction. You'll see an isoelectric baseline, unlike atrial flutter, and AV block may be present. And this is generally a physiological response to rapid atrial rate, except in the case of digoxin toxicity, where there is an actual AV node suppression due to the vasotonic effects of digoxin that results in a slow ventricular rate. The pathophysiology of atrial tachycardia kind of centers around this single ectopic focus. The underlying mechanism can involve reentry that's triggered by activity or increased automaticity. It may be paroxysmal or sustained, as in intermittent or sustained. Multiple causes include digoxin toxicity, atrial scarring, catecholamine excess, congenital abnormalities, or it may be idiopathic. Sustained atrial tachycardia may rarely be seen and can progress to tachycardia-induced cardiomyopathy. Grab out your handout, and you may need to pause this video just so you can take a look at the slide. So some of the ECG characteristics that you're going to see with atrial tachycardia is a fast rate, 150 to 250, and the rhythm tends to be regular when you're looking at the ventricular rate. P waves are normal and upright and uniform, but they can differ in shape from that sinus P wave that you're used to seeing. The PR interval tends to be short, of less than 0.12 in really rapid rates. QRS complexes are normal but narrow, 0.06 to 0.10 seconds, and can be aberrant at times. Multifocal atrial tachycardia. Multifocal atrial tachycardia is a tachycardic version of wandering atrial pacemaker, in which the atrial rate is more than 100 beats per minute. This occurs when multiple areas or ectopic foci within the atrium generate consecutive action potentials that are all conducted to the ventricles. Thus, the QRS complex will be preceded by a P wave. The P wave will have different morphology because they originate from different areas of the heart. And you must see at least 3 distinctly different areas of origination to qualify as multifocal atrial tachycardia. Multifocal atrial tachycardia frequently occurs in the setting of severe lung disease, and more specifically, during an exacerbation of lung disease. The rhythm is generally benign, and once the underlying lung disease is treated, it should resolve. If rate control is needed, the historic treatment, although there's not much evidence to support it, has been verapamil. There is no thromboembolism risk with MAT, as you see with atrial fib and flutter, because the atrium are contractile in MAT. If the heart rate is less than 100 beats per minute, then the rhythm is actually wandering atrial pacemaker, or WAP. Electrolyte imbalances can impact your cardiac rhythm to a large degree. You will be seeing a lot more about this in your lesson in Moodle in step 2. And there's a handout called Electrolyte Handout that discusses how imbalances really impact the cardiac rhythms. So for right now, we'll leave this as a placeholder, but know that in your lesson, you'll hear a lot more about it. Sinoatrial block. The impulse originates again in the SA node, but gets blocked for one cycle. It travels down the usual pathways after that, so it looks fairly normal sinusy, but you'll see in the strip below where the impulse is blocked or arrested in the SA node for one cycle, and then you'll see an escape junctional or ventricular beat follow. Go ahead and grab your handout, and you may need to pause the video while you review this slide. The ECG characteristics of sinus arrest. The rate is usually normal, but can vary because of the pause. The rhythm tends to be irregular, and the pause is of undetermined length. There can be more than one complex omitted, and it's not the same distance as other P to P intervals in the strip. You may need to grab a longer strip just so you can see this. P waves are uniform in appearance. They tend to be the same shape and positive, for example, in lead 2 and round, and there is one P wave for every QRS complex. You can see that the PR interval is consistent with measurement from beat to beat, and the QRS duration and the QT intervals are normal. In this strip, you see a sinus pause or rest, and it's defined by the transient absence of a sinus P wave on the ECG that may last from 2 seconds to several minutes. The strip at the top of the page shows an escape beat. You can see that there was a pause or an arrest, and that often allows for an escape beat or rhythm to occur. But these lower pacemakers can be sluggish if they're coming from the junction or from the ventricle. They can be sluggish or even absent. A pause that is 2 seconds or longer does not necessarily indicate disease, since it can occur in the normal heart. But the longer episodes of sinus arrest can produce some serious signs and symptoms like dizziness, presyncope, syncope, and sometimes sudden death. So you see at the top of the page a great example of a pause or an arrest, and you can tell by this strip it's a pretty long, almost 4-second pause. So what do we do for this patient? Well, obviously, we're going to treat any serious signs and symptoms, but we certainly want to continue to monitor and record and document all episodes and note the length of the pause in seconds. And to calculate that length, we're going to measure the R to R interval around the pause. Count the number of large boxes between those two R waves and divide that number by 5. You also want to note the frequency of the pauses. So for the patient, if it's occurring frequently and they're asymptomatic, we may just need to do pacing, transcutaneous or temporary transvenous pacemaking. Treatment can include stopping medications that suppress the sinus node, like beta blockers, calcium channel blockers, and digoxin. This concludes the lecture on sinus rhythms for the basic ECG course. Thank you for your time and attention.